Yes, I just got on.
Oh, thank you. Very good. Heather, I saw you jump on. Heather Miller. Jacqueline Evans. Tony Huma. Ann Stafford, I think I saw you come in, right?
Yes, I'm here. Thank you.
Thank you. Ms. Ramos, thank you. I see you. Debbie Johnston, I think I saw you come in.
Yes, I'm present.
Hi there. And Dr. Zedler.
Hi, I'm here.
Awesome. Great. We have a forum. Thank you, everybody. Okay. Appreciate that. So item number 3, the chairman's report, the attendance report. Just a reminder that if you miss 2 or more meetings, the Bureau will send out a communication with you regarding whether or not you want to stay with the committee or not. Item B, the vacancy report. We do not have any vacancies. So thank you all for your continued service. And the 2023 meeting schedule is available online through that link. I'll show you that now. Okay, we'll move on to the Bureau report for department updates. Chief Garcia.
Good afternoon. We want to remind everybody to please, if you haven't already, subscribe to our department and Bureau updates. We've sent out several delivery announcements most recently. This week, we have honored National Crash Responder Week here in Arizona and shared a blog with all of our delivery subscribers. There were a few other delivery updates that went out since PACES last convened. One of the most notable is that EMS scope of practice was updated based on national standards, and that new scope of practice went into effect on September 22nd of this year. Our updated table 5.1 is available on the ADHS website for anybody that wants to check it out. I know we have some other items that we'll cover a little bit later in the agenda. At this point, I just want to plug our 911 dashboard that's gone live on the department's website. We also plan to do a blog on that one later next week. And we're pretty proud of the fact that our partnerships with so many of the EMS agencies across the state has allowed the department to share almost real-time information on the EMS system. And there's quite a bit of dashboard information that's refreshed on our website routinely. We're working on our EMS annual report right now, and we look forward to being able to look at pediatric data specifically as we comb through that EMS annual report to share with you all. Most recently, we did publish our Arizona trauma report. That's the annual report that gets posted on our website every October. And that one does highlight pediatric trauma incidents. I believe there are over 6,000 pediatric cases reported in the trauma registry each year. And this year we were able to look at the top 5 causes of injury related to peds. If there are any questions about those most recent reports or dashboards, please let us know. And I'll segue into introducing some of our new staff members. They're probably fatigued by now because we've made them sit through 4 meetings and introduced them over and over again. But in no particular order, we have Brian Hubble, who's joined our team as the new UN and Rates Manager, Stephen Ferris, EMS Regional Coordinator, Russ Lindholm, EMS Regional Coordinator, and in the back, we have Jeff Kerr, Compliance and Enforcement Manager. But we're thrilled to have them on board and look forward to you all meeting and working with them. That's all I got, Adam.
Thank you, Chief Garcia. Okay, moving on to updates. The regional contracts have been sent out, and I mentioned the PEC position has been sort of elevated to a regional PEC. We've asked the regions to begin identifying some individuals that would be interested in that position, and we have to say thanks because individuals are already reaching out interested in that. So I appreciate that, especially the Ames region, northern region. I see some people are contacting me for that, that are interested. So that means to me that you're getting the word out, and I tremendously appreciate that. We're still working on, we're still sort of drafting the functions and the duties of this person, but ultimately the high-level view is that they'll be used as a conduit for information, for data sharing, both directions. Both, you know, we would like to collect data and also to pass things down. And so that's on the outset, that's really what that person is going to be most valuable for. Item B for updates. If I could share my screen, Shelley.
Yes, I will stop sharing.
So the EMSC has recently submitted our grant application, and I thought it would be prudent to just quickly go through some of the points regarding it. Hopefully you can see that. Okay, so the high-level view is the grant cycle is good for 4 years. The 5th year is a performance-based year that could extend that 4 years to a 5th year. The EMSC grant cycle or the award issue date is April 1st, 2023. It is a competitive grant, but we fully expect to be awarded that funding. The major changes in this round of the grant cycle is the increase in the overall funding that we can request, which is up from 130 to 205,000 yearly. This means for the regions that we'd like you to start thinking about pediatric training and supplies that you need, because we are increasing the appropriation for that from $5,000 to $10,000 for each region regarding pediatric specific training equipment, what have you. The third major change in this is that our PACES representative, Jordana Carpenter, will become an integral partner to the EMSC in this grant cycle. So she and I are going to be working in tandem to the goals that I'm about to discuss. So for the 4 goals that the grant has asked of us are really sort of 2 sides of the same coin. Goals 1 and 2 are just that. They're 2 sides of the same coin. They are, goal 1 is expand the uptake of pediatric readiness in emergency departments. And this is accomplished through establishing a standardized pediatric recognition program. Luckily for Arizona, we already participate in the Arizona's American Academy of Pediatrics chapter in their hospital ED recognition program. The second bullet there I have bolded because that really is the critical person that would help us facilitate these measures. And this is identifying pediatric emergency care coordinators in the emergency departments. And third, ensuring hospital emergency departments weigh and record children's weight in kilograms. Some of the goals that the objectives we identified for this goal. We want to continue to support the AZAAP in getting EDs in hospitals pediatric recognized. It's a bit lofty, but 75% of Arizona hospitals is our target for pediatric recognized programs through that pediatric prepared emergency care program. And as I mentioned, that the second bullet point, the PEC is integral to facilitating these goals as a conduit for us. That PEC, whoever we're looking for, it can be anybody. It can be physicians or nurses or tech staff. It's anybody with a real world vested interest in forwarding the pediatric agenda. And typically at these meetings, it will usually be one of us that will pipe up and say, okay, I'll go ahead and do it. But I realize we're all double duty. We're all tasked out given the current state of things. And so if you could reach down into your EDs and reach down into your staff and find somebody that isn't doubled up, that would have the ability to commit some time to this, that would be greatly appreciated. And so asking you not to take on a further burden on yourself and find more individuals that would be interested in contributing. gone to this slide a minute ago. As we recruit those PECs, we need to create a list management to keep track of these PECs so that we can maintain relationships with these PECs. And again, that data going back and forth is paramount. Again, lucky for Arizona, we and the AAP, they already host this program, and so we just want to increase that, increase the awareness of it, increase the number of hospitals that are associated with that pediatric recognition program. The other side of this is the pre-hospital recognition program, which we don't have as of yet. This is, we'll talk about this later on in terms of a work group, but I will lean heavily on PACES and its members to assist me in standing up a pediatric readiness recognition program for the pre-hospital services. We'll go through some of the goals for this. But again, increasing PECs in the pre-hospital EMS agencies is that counterpart to a PEC in the hospital setting. So the more pediatric emergency care coordinators we have, again, that they are the most vital link in helping us stand this up. This is a lofty goal, given that it's going to have to be from the ground up. We're going to have to look at existing pediatric recognition programs, as well as some of the components that they use in terms of verbiage that describes their goals. Some of these bullet points describe our timeline, and so by the first year of the grant cycle, by March of 2027, I'm sorry, by January of 2025, that gives us a year to hash out everything that's necessary to stand up a pediatric recognized EMS agency. I do realize that we already have a pre-hospital EMS Premier program that includes a small component of pediatric involvement, but this is fully geared towards pediatrics in every regard. And so with your help, hopefully by early January, we can actually launch this program, and in the coming years, we can monitor it and reiterate it to see what we can do better about it. By 2027, we'd like to see 20 EMS agencies have a pediatric recognition program with some emphasis on rural service, because our state is so big and resources are so thin, we would like to always make sure we are maintaining a rural point of view. And then, not lesser than, but by 2027, 60% of EMS agencies have a process for pediatric skills check on the use of pediatric equipment. The data agencies we work for fully acknowledge that frequent checking of paramedics and their pediatric equipment is necessary, as those skills tend to fall off rather quickly after a pediatric training. And so this process helps to ensure that we're maintaining a high standard of care regarding pediatric specific equipment. Okay. Again, I should have moved forward a little bit sooner. Again, I'm going to use PACES and your expertise to help stand this up. We're going to use some of the existing materials from other states, and as proposed by my data centers and my other stakeholders to lean against in terms of what kind of information we're going to use to judge these agencies, and help me to develop communication and recognition toolkits so we can promote this project. Oops. All right. Sorry, kind of disappeared from my screen there.
So, maybe if I can just tie in, back to goal 2. I think this is really a great opportunity. It sounds like a big ask for EMS agencies, but I think really this is how this is built out. And one of the opportunities that we could really look at is that we do have the requirement for 5 hours of pediatric specific training that's currently in our rules for recertification for paramedics. And I do think there's an opportunity that we could potentially kind of help to align some of that educational requirements with the role of this pediatric readiness in the EMS system. So certainly we would want to have this really go to EMS Council as kind of the governing body that helps oversee the EMS system. I think that will help with the buy-in of this. if we really take this kind of early on to EMS Council and 4 regional councils, and some of our other kind of big EMS partners that we know of statewide. This is something that Chief Garcia and I have really recognized, is that there's different people that attend different meetings, but there's certainly, we have now, I think, a pretty good idea of how we can hit kind of all EMS agencies and EMS providers for different things. But I would definitely say for Goal 2 specifically, we would launch EMS Council more on there very early on.
Thank you for that. Yeah, an absolutely good idea. Okay, Goal 3, increase pediatric disaster readiness in EDs and pre-hospital EMS agencies by ensuring that disaster plans address the needs of children. For this goal, we're utilizing the Pediatric Workforce Development Pediatric Readiness Assessment Tool. This is a yearly assessment and survey where voluntary hospitals will take the survey for us and let us know what disaster plans they have, what kind of considerations are within, and what items could be added to that. So we are helping our data centers expand those data grabbing surveys. And so you see here, we'd like at least a third of our state's EMS agencies and hospitals to have disaster plans specifically geared with regard to pediatrics. And we have, as we move this goal forward, we have plenty of resources that we can lean on moving forward. And so, let's see. We're going to use the, sorry, I should keep advancing a little bit sooner. Participating in the 2024 National Pediatric Readiness Assessment. Last year we took it, and we'll take it again next year. And again, this is just our way of finding out who has disaster readiness policies in place, what do they need, and what is contained within those. That last bullet point, identify contact information for hospital emergency managers. That's going to be tandem as well as looking for those PECs in both those pediatric emergency care coordinators in both the pre-hospital and the hospital settings. Okay. And lastly, big thanks to Jordana Carpenter for helping us achieve Goal 4 so soon. Prioritize and advance family partnership and leadership and efforts to improve EMS systems of care by including and engaging family representatives who can speak to the emergency needs of children in their community on EMS state advisory committees. And so Jordana has agreed to contract with us to provide her point of view to allow us a broader base of information on which to act. And so we've given her a lot of lateral movement. She will start with us as the grant cycle begins. And so part of her responsibilities are, well, we'd like her to name the goal that she wants to achieve. And so we are asking of her to identify and take the lead on implementing one of her grassroots projects, whatever she sees most fit. We're absolutely going to support her in that, and then she'll continue to attend our PACES meetings and give her viewpoints. So Jordana, we very much thank you. Okay, those are the 4 goals regarding the most recent grant application. That's the driving push between them. Driving force of that grant application is the accomplishment and measurement of these goals. I'll pause for any questions if anybody has any. Otherwise, Shelley, I think I can give it back to you.
All right. I'll display the agenda.
Well, can I say thank you to Adam and Julia for all their work grant writing and making sure that our state is able to be competitive for those funds. We really appreciate you making sure that we pull these resources into the state so that we maintain readiness here in Arizona.
Thank you, appreciate that. Okay, we'll move on to discussion and action items. Item A, discuss and approve draft minutes from July 2022. We'll take a minute to review them, but thanks, Chris, appreciate that. Take a minute to review, but I'll, if I could have a motion to approve after review.
I got it. Up here.
Oh,
Where'd they go?
It's Jordana, I have a question.
Thanks, Jordana, appreciate that.
It's gonna go delay on my end.
Sorry, guys, just give us just a quick second. Take a moment to review that.
Maybe it's been.
All right. Is there any discussion regarding previous meeting minutes? Hearing none, can I have a... Sorry, go
Heather
ahead.
Miller to approve.
Oh, thank you, Heather. Yeah, can I have a motion to
Sure.
approve? Appreciate that.
This is Ann Stafford, I second.
Thanks, Ann.
All those in favor?
All in favor, say aye.
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 Any opposed? Okay, thank you.
Chris, I stand, or as presented.
Okay, the minutes are approved as presented. Everybody. Okay, we'll move to item B, the draft seizure training from the training gap work group. But yeah, I'll grab the screen again if you don't mind.
And stop presenting.
Okay, hopefully you all see that. Okay, so there was a discussion in the training gap work group about where can we better the training for our paramedics regarding pediatrics, and all pediatrics are high risk and low frequency, and that is the indicator for training. One of our group's members suggested pediatric seizures, and I think that was completely appropriate given the amount of seizures that we see, and as you'll see. So my motivation for this is to solicit your correction for this and give me some feedback on it. Some of the background for this is utilizing my data center, the EMSC Improvement and Innovation Center, the EIIC, so many acronyms. They have some fantastic toolkits that are ready for distribution. They count for CE hours, and the thought was to integrate with our state as a background, integrate that training using the EIIC's ready-made toolkits. And so there's a few slides here, but again, I'm looking for your input or edits that you may have. But just trying to keep this down to a most basic 1 hour CE claimable 1 hour training module regarding seizures. So take a moment to review these as I move through them. I believe I did link this to the calendar invite if you wanted to download this and review it for yourself. Given the gravity of seizures, you can see between these two bullet points that this is a large population that we see frequently. And so it was completely relevant to bring updated training to our EMS providers. The integration with the EIIC's toolkits are sort of sprinkled throughout the slide. And so these are all hyperlinked to those websites, and they link you to different sort of items. Some of them are podcast style, audio only. Some of them are interactive, but this is how we are sort of framing this in the context of Arizona and utilizing those pre-made toolkits. The model of this was something that I wanted to sort of push, was that there are several toolkits from the EIIC, and it would be silly not to take advantage of all of them. And so as we move forward with more trainings that we identify on needs-based assessment, we can pull from those. And they don't have a full library of everything, but the libraries they do have is what I'm saying we should utilize. And so this was sort of a model for the training that I wanted to sort of carry forward, utilizing those good resources. And we'll talk a little bit more about that with the behavioral health work group.
Adam, I'm sorry to interrupt you, but Dr. Woolwich had sent out an email stating that he wanted to add D for dextrose on the last one for ABCs.
Oh, you're absolutely right. Let me share. I should have mentioned. Yeah, Dr. Woolwich got a look at these, and he did offer some edits. They're over here in the comments. If you can't see that. No, sorry.
I just had a comment about it. With kids who are with epilepsy, some of them run at a baseline, what we would consider textbook hypoglycemia. So yes, checking it is a great tool, but also keep in mind that if the kids have epilepsy, it's good to know if their baseline level is hypoglycemic or not before we start giving them dextrose or anything, because it'll change things.
Okay. How would you want to include that in this slide?
Maybe checking in with the caregiver to see if they know the baseline of the children's hypoglycemic state.
Okay, I will work that in there and send it out and see if that's the way you want to word it. Yeah, Dr. Woolridge offered these over in the comments. I just copy paste that out of his email, and I absolutely agree with him in this one. So I think your comment with the addition of that D for dextrose, especially in this case, is super pertinent. So let me make those edits as you guys give me them. If you can still see this, I'll just kind of leave the screen up so you can kind of see Dr. Woolridge's comments about these. Thanks, Jordana. Can you all still see that?
Might be a little small.
Might be a little small. All right. If you have edits, then I'll back out and show what Dr. Woolridge made.
Adam?
Yes, sir.
This is Chris. I mean, I know there was a comment on this on the Rampart trial, but the SEMSO also puts an emphasis on that IV is not necessary in the setting of any seizure, pediatric or adult. And I see this consistently by EMS where there's perception that they need to get an IV before they give medications. And I think that should be strongly emphasized. Again, the SEMSO says that IV is not necessary with the excessive perception of low dextrose.
So I think for anyone who's not aware about the Rampart study, this was a randomized controlled study done across the United States. Glendale was one of the study sites for this, which looked at seizure dosing, comparing IV Ativan or lorazepam to IM midazolam, and demonstrating essentially equivalency. And so the recommendation is for IM midazolam to be the first line. So I would recommend flipping the order of those, just kind of to stay in line with that national guideline and what we use to teach in the state.
Excellent. Yeah, absolutely. And that is exactly what Dr. Woolridge suggested, was to put midazolam first. Thank you for that. Thanks, Chris.
This is Jordana. I have another comment about the medications.
Sure.
Some of the families who have kids with epilepsy will have these medications on hand, and they will have already given some of these medications. So it might be wise to check with them to see how they administered it and how much, so we don't overdose these kids on some of the meds. They do have nasal and rectal and wafer, like oral stuff that they do give at home.
Okay, that's solid information, Jordana. Thank you. Yeah, those parents as resources are paramount, so we'll make sure we highlight that. Yeah, thank you.
Adam,
Yes, sir.
based on the literature that I know, which I mean, this is from my epileptology department, the number one cause is seizure medication non-compliance. So whether they're growing out of the medication, they're intentionally decreasing the medication, or they forget the medication altogether. But that's the number one cause of pediatric status epilepticus.
Very good. That sort of ties in with Jordana's comment as well, is listing those parents for the history on that. So thank you. Definitely have that. I should probably not refer to them as benzos. I should probably use benzodiazepines.
I think the one thing to consider for an educational perspective, especially for pre-hospital, with the pediatric population, many of these children will present with kind of atypical from what we think about in the adult or older teenage population, where you may just see kind of repetitive rhythmic movement versus your generalized tonic-clonic seizure. I think this might be an opportunity to expand on that, and that might be one of the breakout things that when you click on that, you get more information.
Yeah, very good. Okay.
But I think that is something that typically we do see sometimes missed from whether it's an adult physician that doesn't see a lot of kids or the pre-hospital providers, that this atypical presentation is more common in younger children.
So some additional information on those atypical presentations.
And and where you have the hyperlinks here, I'm not sure how much information that takes that to, and that might be discussed in those hyperlinks.
They might be. I have listened to them, but I don't have them. I don't know them well enough to. But they may have those in there. But I tried to include the entire breadth of the seizure training that those are linked to. Is that not working for you though?
I was just seeing if it was opening.
Oh, okay. Oh.
Sorry, it's Jordana again. I have a question.
Sure, go ahead.
So I don't know how prevalent it is, but some kids have vagal nerve stimulators for seizures as well. So that might be something to look into as well for education.
Vagal nerve stimulators?
Yeah, it's a VNS. So basically it's a pacemaker for the brain. So like we have to be careful with magnets and those types of things, and we have to swipe it, and it's used kind of like a medication to help interact in stopping the seizure.
Like, so are you referencing some techniques that would satiate those vagal nerve stimulators?
Yeah, so like we have to be careful with having any kind of magnetic field around kids that have VNSs, but also when we do use the VNS, it helps to interact and stop the seizure to lessen it.
Okay.
They use it as a medication tool.
Okay, that is somewhat new information to me. I'll have to look into that. Let's maybe we can meet up and I can learn a little bit more about that specifically.
Sure.
Okay. And this last slide is takes you to the same site, but it is an interactive sort of simulated patient question and answer style format. Something I think is like 10 questions that basically just cover all of the training that was aforementioned in the links. And I don't know why it's not working when you click on it. If anybody else clicks on these, if anybody else can go into the calendar invite, open it up. I believe those links are active. I'm just not sure if it'll get through.
I went to
Did you?
on the calendar invite, yeah. But it's just right.
Okay, well, maybe I have a technical problem. They work when I click on them, but maybe it's something I'm doing wrong here. Okay. Other than what's, do any other members have any edits or further input? Everything I've received so far is fantastic, and I can absolutely add that in there.
That's the survey, right?
Yes, yeah, that link
Okay.
works. That's the learning. That's the interactive link.
They can't see it,
Okay.
it's playing right now, but
Where did you pull that from? Just right.
the calendar.
Okay. Okay. Well, if the links aren't working, I will get them working. That's the whole point. So I apologize for that. Okay. If no further edits, I will make those edits, and would I make a motion to approve and go to ED?
We had the seizure training as a discussion item.
Okay, gotcha. Sorry, y'all, bear with me. Okay, if there's no further input for edits or discussion, then we'll move on. We'll bring that to, I'll make those edits, and we will bring that to, with the next step be bringing it to education, Board of Education after pending the edit.
Yeah, when you have a draft ready for both education PACES.
Okay, perfect. Okay, PACES, I will update you when I make those changes, and again solicit for your edits regarding those. Okay, we'll move on to item C, standing items. Discuss, amend, approve work groups and topics. Starting with the first one, I, the behavioral health work group. This work group has been going on for about a year now, and we've had some difficulty with it because it's trying to address a massive problem of ER boarding, and so it's readily identifiable, but the solution just seems out of reach for a group of our size. That doesn't mean that we still can't put together educational material to make a small mark in it, but I believe that trying to accomplish to lessen ED boarding, especially in the pediatric group, is a goal that's going to require much larger input from many groups. But I think that we can still fall back onto a couple of trainings that is published on my data center's website, and I'd like to do it in similar to the same format as the seizure training is, where we put it in the context of Arizona, and we give our pre-hospital providers some additional training that maybe it'll keep pediatrics out of the ED, given some additional information that they've received from this training. And so making a small mark, but obviously we wish we could solve that ED boarding problem, but it's a massive problem. It's a crisis, in fact.
So, Adam, this is Gail. I guess my question for the group is, what is the goal of this work group or training? And I think that's probably the biggest, I think the reason this hasn't really kind of come to fruition is we all recognize that behavioral health is a huge issue across the country. We recognize those numbers have increased with COVID, and that boarding, especially pediatric patients, is a major problem. But in terms of what the goal of a product for this group to put out is, I don't know that the systems are there in place to necessarily keep patients out of the ED. Once the EMS is called, at that point you're in a kind of different situation of the parents or guardian has deemed there to be some type of emergent event, and they're calling for additional resources. And different parts of the state will have different resources available to them. So depending, I think I would kind of task this group to think of what is the actual goal, and is that attainable to move forward, as opposed to just kind of continuing this topic on the agenda.
Any discussion regarding that? What the actual output of the group is, or the viability of it? It's okay that there isn't. Again, I think the reason why it's been stagnant is because we're trying to solve such a large problem with ultra limited resources. And so, if this is something that if this work group, can't seem to make a big enough dent, it's perfectly reasonable to, I don't know, table the work group or disband the work group and put efforts towards other low-hanging fruit. Any thoughts?
Oh, this is Mickey. You did have a nice PowerPoint that you had made up at one time. I know we can't solve the problem, but just getting some education to EMS is helpful, I think, on different types of behavioral health on pediatrics. I mean, you did that little PowerPoint, and I thought that was nice. So.
Yeah, I did, and I did sort of withdraw it a little bit because I wanted to utilize those deeper resources that my data centers have come up with, and so I think you're right, Mickey. I think at most this group can do is put together education for the pre-hospital provider. Maybe it'll help one person, and we can we can say that the behavioral health group produced something for our pre-hospital providers, albeit it might be a drop in the bucket, but it's going to help somebody, I think. And so I think the effort's worth it to put together a 10 or 15 slide set that gives our pre-hospital providers a bit more of a perspective on behavioral health emergencies in the pre-hospital setting.
This is Sandy. Could I add something, please?
Sure.
I think one of the one of the concerns that we see in EMS bringing the kids is it's not a behavioral problem. It is a condition. And I think if perhaps we could do more education, and I don't know that I've seen any, I could be wrong, more on autism, because that's very challenging. You know, I know in our department, we see a lot of kids with autism.
Sure, I think that represents a large portion of the demographic that we're talking about. So I think that's perfectly reasonable to either focus on or include in some of this training that we're talking about producing.
That would be great.
Yeah, absolutely. And so I realized I made that slide set, but again, I kind of withdrew it because I had the idea to utilize those resources from EIC to sort of reframe it and come back with a bit better materials. And so I want to emphasize that training didn't go away. I would just like to revamp it, so to speak, in the same format that this seizure training is in, where it's a bit more interactive and a bit more rich. Any further discussion with the behavioral health work group? I think we have a bit of a direction, some product for EMS providers, but after that, I think we should table the group unless something else happens, and we can focus efforts elsewhere. And if nothing else, that brings me to my next point, the second topic under item C, future work group. Not much here. I just want to get in your ear about what I had mentioned earlier. We will definitely need a work group regarding an EMS pediatric recognition program. And so all I'm asking is that you start thinking about who key stakeholders in standing this up will be, what kind of information and resources do you already have access to, and what do you think you can, what kinds of things can you bring to it that will really help bolster this group. And so not much to discuss there but I want to just get that out on the radar and start compiling some evidence, but the documents and information that perhaps other states have about this. And so I imagine by the next meeting, which will be in March, we're getting very close to needing this work group. And so I just wanted to plant a bug about considering helping me stand up that recognition program. So I hugely appreciate it.
Ask a member if they want to make a motion to form a work group.
Sure. Shelley's advising me on my duties because I'm behind. Can I have a motion to create the work group so that we can solicit for members in the next?
Yeah, if there's an appetite.
Jordana, I'll motion.
Thank you, Jordana. Do you have any seconds?
I'll second Seidler.
Heather, second.
I got Josh, I'm Seidler. Second.
Okay. So the next meeting we'll have a.
We're gonna vote.
Oh, sorry.
To approve the work group.
All who are in favor of approving the creation of the EMS Pediatric Recognition Program Work Group, say aye.
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 Any opposed?
And we're gonna ask for volunteers.
And any volunteers up front? Okay, take your time and think about it.
No, we want pressure.
Okay. All right. Is that it for that show? Or do I say something official?
Yeah, we'll get a work group scheduled between now and the next PACES meeting.
Perfect. Okay. All right. Item D, moving on to item D. We are still looking for and accepting nominations to approve a vice chair. Do I have any volunteers? Can I make a motion to?
You want to name somebody? We need nominees.
Can they nominate themselves to become the vice chair for PACES?
What's the best of them? Tony? Mickey?
A vice chair would fill in and do chair duties if Dale's not available.
And Adam's not available.
I'm not on the committee. I'm not a member of the committee, but how about Chris Ramos?
Chris Ramos, you've been nominated. Any other nominees?
I'll vote for Chris.
He does need to accept the nomination. I will throw that out there.
Is he on the call?
He is.
Okay. Is he anything to say?
He turned his camera off.
Okay, well, do I just,
We need to get confirmation that he's.
Actually, he's not. He's dropped off. He was on the meeting.
Oh, okay.
He's dropped off.
Somebody's on the call.
That's a great time to approve him. He's not there.
I can.
Okay, well, we can, vote on him and his
he
absence.
would be a nice member because he's bridging the gap between education and us. That would be useful, but again. Agree to it.
With him unknowing that he's nominated, we can vote, all of us who approve of Chris.
Okay, well, pending his agreement with the nomination, do I have a motion to, or what is it, Shelley? Do I have a motion to approve?
Yeah, would be the nominee and we would make
A motion to approve Chris Ramos as a nominee and make a motion to, for him as vice chair.
Adam, this is Tony. If you need a motion to make that, I'd be willing to make that motion for Chris. As
All
stated.
right.
Yeah, thanks, Tony. You have any seconds?
I can second. Thank you.
Appreciate it. All right, well, we will ask him or let him know.
All those in favor?
All those in favor say aye.
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 Thank you. Any opposed? Okay. Thank you. Thank you, especially to Mr. Ramos.
I did send him a message and asked if he would do it.
Okay.
Thank you for that.
Okay, we'll move into our last item, discuss RSD, flu season, hospital capacity, and resources for patients and families. I have attended some situational awareness meetings. Those are triggered by pediatric capacity at less than 20%, less than 20% for 2 weeks in a row. I did attend the north and west regions as well as the south regions. And this is just, I don't really have an order or method to this. I'm just kind of bestowing information that I've got. The hospitals are heavily utilizing EM Resource for their bed availability and status updates. Many of the stakeholders, which included EMS agencies, hospital agencies, tribal agencies, governmental, more towards EMS and hospital agencies have described staffing challenges, specifically nurses, having a hard time coming up with the staff necessary to manage these patients. Hospitals in all 4 regions are looking at or entering into contingency mode, contingency standards of care. Hospitals are standing up incident command centers. We are looking at our role in communication and data gathering to see how we can help. Did you have anything further?
I can add on here.
Sure.
So I think more specifically, we had worked with, and I don't know if we have Debbie on the line, right? I know that we have some of our healthcare coalition partners with us now. We sent out through EM Resource a request for information, an EEI, and we actually got 67 responses in the last week from hospital providers. And we are closely monitoring hospital bed availability, and we're appreciative that, as Chair of the Healthcare Coalition, has leaned in to provide those situational awareness updates. What stood out to me, and I think the information that we got back through EM Resource so far, is that out of those 67 responding hospitals, there were 5 that were reporting pediatric transfer issues. Of course, I don't have those 5 facility names, nor would I share them, but I do think that, you know, it shows us that at this point in time in the RSV flu season, we already see a huge strain on our hospital system. And we want to make sure that we do have an awareness of where there might be some limited resources that perhaps there's an opportunity to lean in and help with. It would be nice to know if those 5 hospitals that did report pediatric transfer issues or concerns, if those issues were related to behavioral health placement. We just don't know at this point. The Healthcare Coalition also does a very good job at resource coordination. I think I heard over the last week or so that there was at least one facility that made a request for ventilators. And so, you know, ASCHAIR is a great resource in that regard, that if there are facilities that are hoping to submit resource requests or really get more information available at this point, we really are leaning into partnering with ASCHAIR to be able to provide that forum. And most recently also, Adam attended the National Pediatric Disaster Conference that was hosted in Arizona, but also put on virtually with quite a few folks across the nation. There were quite a few resources that came out of that conference that we shared with some of the stakeholders on this call today. There are some resources just about pediatric disaster planning and crisis standards of care in general that, of course, we are reviewing here at the state. And there were a couple dashboards as well that we wanted to make sure folks had eyes on with respect to significant increases in RSV and flu. Just because RSV and flu season have started early doesn't mean that they are going to continue on as long as we sometimes see. So we are all cautiously optimistic that hopefully, even though it's here early and it's hitting us hard now, that perhaps it'll subside a little bit earlier than normal. But certainly we want to keep eyes on, again, our pediatric bed availability and surge capacity. And we're very, very appreciative of the Healthcare Coalition partners on the line helping to convene those calls so that we do have a better understanding of what resource needs are. I'm sure I'm talking too much, Adam.
No, for those specifics. Yeah, I've just been gathering general information about it, so I appreciate that. Does anybody have anything else to discuss regarding this sort of quote triple-demic that the media has decided to call it?
Yeah, this is Debbie. So, hey, Rachel, you know, regards to your comments, I mean, I will certainly, I think Teresa sent me the list, so I can take a look at that and maybe follow up on some of the behavioral health placement issues, see what I can find out with regards to those 5 reporting facilities. The other question, and maybe, and the answer just might be no, because this may not be the long haul. There was some interest in the southern region, I think in particular, with seeing if the larger pediatric receiving facilities would be interested in standing up something similar to the surge line for load balancing pediatric patients right now. I mean, I know that could be a really heavy lift, and standing up that infrastructure just may or may not be feasible for the time period that we're going to be dealing with. And it also requires those receiving facilities to be interested in doing this. So I just kind of put that out there again as a possibility. I don't know if, Rachel, if you guys have had any chance to discuss that option.
I think it's definitely something that we want to look into further to see if there are resources available, if there's an interest across the system to be able to participate in something like that. Lessons learned during the pandemic with the Arizona surge line in effect were that when we can all work together and load level across the hospital and, for lack of a better term, share the burden, you know, it really worked well in certain circumstances. This is such a unique one, though, with pediatric beds and the limited resources we have across the state. And so it does, as you said, Debbie, require working with a lot of the major players to get a better understanding of how we might collaborate on something like that.
Yeah, I understand the CMOs, at least in the Maricopa County area, are still getting together, and maybe it's twice a month. I don't participate in those calls, but if anyone on the line here, does participate or talks to those folks, maybe that's the place where the conversation starts, because it's most of those facilities are going to be the receiving, although there's also, certainly down in the Tucson area, there's TMC.
And Debbie, would it be fair to say, like, in the absence of a statewide Arizona surge line for load leveling or helping to facilitate those patient transfers, are there other strategies in place right now with sister hospitals and other coordination that, as chair, the Healthcare Coalition might recommend?
No, Astor is very good at, sharing the resources, because it's about mostly emergency managers are the ones sitting around the table. So when stuff is needed, it's wonderful. But when it comes down to care coordination, that really involves higher level, the chief clinical officers or the CMOs. I think it's harder for as chair to sort of do that intervention, that sort of operations piece. Now, if there is, one option would be certainly. There's been some discussions about a transfer, and I don't want to get off topic too much, but let's talk offline, because maybe there are a couple of options, but it's probably better for us just to chat offline.
Thank you for that, Debbie. We definitely want to make sure that we have a good understanding of what resources are available. And thank you to Adam for helping to pull together a lot of what was gleaned from the National Pediatric Conference a couple weeks ago. Certainly, if you have other questions, especially related to EMS for children, we want to thank Adam for being a point person for that.
Okay, yeah. Any further discussion regarding item E?
Chris Ramos rejoined. You want to tell him the news?
Mr. Ramos, you were unanimously voted to become vice chair. Would you accept the nomination?
As long as there's perks, Adam, as long as there's perks.
Absolutely. There's snacks and drinks. All right. Do I have to do anything official with that? Okay. Well, I appreciate that, Chris. Thank you so much. It's very appropriate for you to help us out and continue helping us out, bridge that gap in education. So we appreciate everything you do, and I'm sure Dr. Woolridge will be pleased as well. So thank you doubly.
Chris, we do have a gavel in the room with us, and so as vice chair, if you would like to use the gavel, you are welcome to it.
My wife has taken mine away, so I'll take that one. Thanks.
There you go. Well, thank you so much. Okay, if there's any agenda items to be considered for the next meeting, please send them to me, and I will get them on there. And we'll move to call to the public. Okay, hearing none, we'll move forward to the upcoming events. See you there.
I have a flyer to display for the EMS-based hospital and medical direction seminar coming up that Martha Salgado is coordinating.
Thanks. Appreciate it. If nothing further, can I have a motion to adjourn?
You call for a motion, you got to vote on it.
This Jordana, I'll motion.
Heather
This is
Miller,
Tony, I'll second.
Thank you. Okay, we'll adjourn the meeting at 2:31. The next meeting is March 16th, 2023. Thank you.
You can vote.
Oh, didn't vote. Sorry, I'm terrible at this.
Thank you, everyone.
I'm so glad Chris is doing it.
Thank you, everybody. Almost got it.
Not officially. That's probably the.
I had like 8 years of experience before I got with the Bureau of these things.